Hi everyone. In this session, I will be speaking on how to interpret the culture, identification, and sensitivity reports of microbiology. Let us first understand the key terms such as MICs and breakpoints. What do you understand by MIC? MIC stands for minimum inhibitory concentration. Now, what is MIC? MIC is the minimum concentration of an antibiotic which is needed to inhibit the visible growth of an organism. Now, how it differs from breakpoints? Breakpoints are different in the way that they are the cutoff or the discriminatory concentration used in the interpretation of these MICs, whether these MICs are susceptible, intermediate, or resistant. So these breakpoints are like discriminatory cutoffs, which is determined by organizations like FDA, CLSI, or UCAST. Now that was about the definition. Let us understand how to use it. How to use it for identification of a sensitivity as whether it is susceptible, intermediate, or resistant. Now, what do you understand by susceptible? Susceptible means that the organism will respond to the antibiotic with the doses recommended. While resistance means the organism will not respond to the antibiotic with the normal doses recommended. While the intermediate means that clinical response is likely to be less than as compared with the susceptible strain. So in such cases, we will need to have a higher dosage or increased frequency in other such alternatives. So this is about the terminologies susceptible, resistant, and intermediate. Now, how to use these breakpoints to add to interpret the MICs as susceptible or intermediate or resistant? Let us take an example. For example, E. coli has from a sample, say urine, has an MIC of about say 1. Break this chart. This chart is the breakpoint chart given by CLSI. CLSI, which stands for Clinical and Laboratory Standard Institute. So CLSI has given the breakpoints to interpret the MICs whether it is sensitive, intermediate, or resistant, or whether it is SDT. Now, if from a particular sample, if you get the MIC as 1, so the MIC is less than the susceptible breakpoint, so we will interpret that MIC as susceptible. If the MIC of the E. coli would have been 16, which is more than the resistant breakpoint, that is 8, I would interpret that MIC of 16 as resistant. If the MIC would have been 4, I would have interpreted as intermediate. So this is how the breakpoint chart can be used to interpret the MIC whether it is sensitive, intermediate, or resistant. So when we get a microbiology report, it is not the MIC, but it is the breakpoint that help us to understand whether it is a susceptible, intermediate, or resistant. Again, this breakpoint differs from organism to organism and from sample to samples. For example, Streptococcus isolated from a CSF sample will have different breakpoints, and from a non-CSF sample will have a different breakpoints. So when we get a microbiology reports of such samples of from such organisms, see the breakpoints, particular whether it is of CSF or a non-CSF, and for example, as other terminology is susceptible dose dependent. We learned about susceptible, intermediate, resistant. Now it is susceptible dose dependent. This is an interpretive category wherein from experimental studies it has been proved that if you use it is similar to intermediate, but it is from experimental studies that it has been proved that higher dosage or more frequent administration or extended infusion can help us to achieve the desired pharmacological effect. For example, cefepime, the normal dose is 1 gram per 8 hours or 30 minutes. For MIC less than 2 micrograms. But if it is SDD, then a higher dose such of 2 gram per 8 hours may be given to achieve the pharmacological effect. Will another example, if the cefepime is reported as sensitive less than 2 MIC, then 1 gram every 12 hours is enough. But if it is SDD and MIC is 4, then 1 gram for 8 hours or 2 gram for 12 hours. But if it is SDD with MIC 8, then 2 gram over 8 hours. So when the microbiology report states that it is an SDD, that is susceptible dose dependent, then we can either increase the duration the frequency of administration or uh, the amount of the antibiotic. So that was about susceptibility, intermittent resistant, and SDD. As I will repeat again, it is not a MIC, but it is a breakpoint that determines whether that MIC of a particular antibiotic against an organism is susceptible, intermediate, resistant. Another guide that can help us to understand the MIC will be to use efficacy ratio or susceptible breakpoint to MIC quotient. Now, what is efficacy ratio? It is a ratio of it is a ratio of the susceptible it is a ratio of the susceptible breakpoint to the susceptible MIC of that particular antibiotic. It is necessary to compare the MICs of different antibiotics against different organisms. So efficacy ratio help us to understand the whether the particular MIC is susceptible or not. The therapeutic efficacy is a misnomer that is often used. However, therapeutic efficacy is related to the risk or safety of the antibiotic. The correct term will be efficacy ratio. Therapeutic efficacy is directly proportional to the efficacy ratio. Efficacy ratio is a significant factor in antibiotic selection and for empirical therapy. So we'll repeat again. It's the efficacy ratio, that is a quotient of susceptible breakpoint to MIC that helps in antibiotic selection and not just the MIC alone. This all depends, interpretation depends upon the breakpoints. If suppose when for not for all antibiotics breakpoints are available, for antibiotics which are where breakpoints are not available, we take help of epidemiological cutoff value. The epidemiological cutoff value has sets of MICs as wild type and has a sets of MICs as non-wild type. When an epidemiological cutoff value says that a particular MIC is a wild type, that means it doesn't have any resistance mechanism. And if the ECOF value or epidemiological cutoff value says that whether it is non-wild type, that means that MIC has a resistance mechanism. So ECOF value will only help us to understand whether the particular MIC reported is wild type or non-wild type, or has no resistance mechanism or resistance mechanism. For example, azithromycin against for Shigella flexneri. If the azithromycin MIC is say 4, which and the ECOF breakpoint is if ECOF MIC is about 8 and the MIC obtained from testing is about 4. So if it since it is less than the ECOF, it is a wild type that doesn't have any resistance mechanism. If the MIC of azithromycin against Shigella would have been 32, which is more than the non-wild type ECOF, that is more than 16, then it is interpreted as a non-wild type, that it has a resistance mechanism. Similarly, if we have ECOF for Neisseria gonorrhea or for Clostridium difficile, where for example for vancomycin it is less than 1 for wild type, more than 2 for non-wild type. So ECOF can be used when breakpoints are not available to see whether there is a resistance mechanism present or absent only. So it is not ever possible that it is possible to report all the antibiotics in a single report. So the microbiology often makes use of a representative antibiotic which can be extrapolated to other antibiotics. For example, amoxicillin can be its predicts susceptibility of ampicillin. Clindamycin predicts susceptibility of lincomycin. Erythromycin predicts susceptibility of azithromycin, clarithromycin. So single erythromycin susceptible result can be used to predict susceptibility to other antibiotics like azithromycin, clarithromycin, and others. For another example is oxacillin. It predicts susceptibility to methicillin. So if oxacillin is sensitive, methicillin is sensitive. Resistant, then methicillin is resistant. However, again, if oxacillin is resistant, then it will indicate against resistance against beta-lactam group of antibiotics like penicillins, cephalosporins, carbapenems, and monobactams. So this is how a single antibiotic result can help us to extrapolate the results of other antibiotics. Another thing to consider is intrinsic resistance or natural resistance. Some organisms are natural resistance against different group of organisms. For the most commonly isolated organism, enterococci is resistant against most commonly prescribed antibiotics like aminoglycosides or cephalosporins and glucosamines. So such natural resistance needs to be taken into consideration while prescribing therapy. Often in the provisional report, microbiologists often gives identified organism in this provisional report. So that from that provisional report, one can identify an antibiotic for empirical therapy based on natural resistance. So the culture and sensory report doesn't tell you which antibiotic to use. It has to be interpreted, taking many factors into consideration. It is an in vitro phenomena, so susceptibility is subject to very great variability. So my microbiology lab needs to perform the testing very rationally and very accurate way for the same. Let's take examples and understand how to interpret the culture and sensory report. For example, a 42-year-old female with UTI symptoms on ciprofloxacin. E. coli with this pattern of sensitivity, wherein uh, ampicillin resistant, amikacillin sensitive, cefazolin resistant, ceftazidime resistant, and cefepime is SDD. Now, which antibiotic? For selection, always make use of this chart of Ambler classification, which mentions about ESBL or MBL or OXA or cephalosporins. What do I understand by ESBL? ESBL means resistance to cephalosporin till third generation. Carbapenems means resistance to carbapenems. And MBS means resistance to carbapenems. OXA means there oxacillin or and carbapenems. So cephalosporins means there is a hydrolysis of cefamycin, that is cefoxitin, or it is an MC producer. Now, how to make use of this table for this particular case? Now, since the case the case has E. coli, wherein cefamycin is sensitive, but other cephalosporins were resistant. That means it was an ESBL group of organism. So, the pathogen is an ESBL producer. It does not produce MC, it does not produce MBL, because carbapenems were sensitive, cefoxitin was sensitive, so it is not an MC, it is not an MBL. Again, for ESBL, which antibiotic to select? The green ones are the susceptible, yellow ones are the intermediate, and red ones are the resistant. So we will select that antibiotic using this chart, which will be sensitive. Now the particular organism from this case study is an ESBL producer. So we will see the ESBL column, and here it is says that cefamycins or carbapenems will be the drug of choice. If it had been an MC producer where cefoxitin would have been resistant, then the drug of choice would have been 4th generation cephalosporin or carbapenems. If it had been an MBL producer with carbapenems were resistant, then the drug of choice would have been either aztreonam or would have tried with decreased susceptible antibiotic in combinations such as beta lactamase inhibitors and carbapenems or monobactams. So there are novel agents which are specific niche. For example, aztreonam with avibactam, which is active against KPC, NDM, and OXA. Now these are the resistance genes that we can identify from molecular testings. So in such case, if even molecular testing reveals resistance genes, we can resort to this combination of antibiotics which are novel for against different resistance genes identified. So this case was a community acquired CTX M15 producing E. coli, where different group of antibiotics were resistant. Hence, it is in a multi-drug resistant organisms, and it is possible of carrying multiple resistant genes to different classes of antibiotics. Particular infection control precautions needs to be followed. This is a slide of various beta lactamase inhibitors, beta combinations that we can use based on the Ambler classification. For example, if we see piperazine tazobactam or tazobactam, it is not doesn't have an active against KPC or CTX. Sorry, it doesn't have active against KPC or MBL or MC or OXA. So while avibactam has activity against KPC, HHV, TM, CTX. So this and based on this enzymes identified, the different classes of novel antibiotics can be used against particular resistance genes identified. That was about illustration how to interpret the culture sensitive result. What do you mean by MIC and breakpoint? It is not just the MICs, but the breakpoints carries value in interpreting of this MIC as susceptible, resistant, or SDD. Then we have learned about ECOF value when breakpoints are not available, and we have seen a case study how to make use of the resistance genes for selection of antibiotics. We will see in details in next session through other interesting case studies how to make use of sensitivity results for antibiotic selection and dosing. Thank you.